1 minute. Yeah.
Ma'am, we are live.
Good evening, everyone. Welcome to iFocus. Today we have lecture 189 and retina session 41. And we have a very important topic for today, that is central serous chorioretinopathy. And Dr. Avnindra Gupta sir is here to teach us about CSR. Sir is a vitreoretina specialist. He has done his MBBS in PHU, followed by his MS in the same university. He has finished his fellowship in retina, vitreoretina from Aravind Eye Hospital, and has worked in many prestigious hospitals. Today, he is especially here for all of us to teach us about CSR, and I hope the participants and all the PG students will benefit a lot from this class. So please proceed with your class. We are ready to listen.
Can I share my screen?
Yes, sir.
Can you see my screen now?
Yes.
Good evening, everybody. First of all, I'd like to thank Dr. Santosh Munawar, the person behind iFocus for years together. The third, fourth, and pillars, Dr. Lalit Verma, Dr. Mahipal Sachdev, and Ritika Sachdev, for carrying out this educative program. Today, my talk is central serous chorioretinopathy, which is the most common cause of decreased vision and the patients encountered in the OPD. Central serous chorioretinopathy is characterized by serous detachment of neurosensory retina with or without pigment epithelial detachment. In 1866, Grafes first described recurrent central retinitis as central serous retinopathy, but actual diagnosis or description of idiopathic central choroidoretinopathy came from Gass, who provided the classical description of the pathogenesis and clinical features of the condition that we call as an CSCR. If we look into the pathophysiology of CSCR, there are hyperpermeable choroidal vessels. Because of this, there is an increased hydrostatic pressure. This overcomes the barrier function of retinal pigment epithelium, leads to formation of pigment epithelial detachment. There is a breach in retinal pigment epithelium, which allows entry of fluid into the subretinal space. Other pathogenesis which has been postulated is aldosterone or MR pathway, which has been postulated in pathogenesis of CSCR. CSCR is usually an idiopathic disease, affects young male between the age of 28 to 41. It's a macular detachment, not macular edema, and is associated with stress, that is type A personality, hypocholesteremia, that is Cushing syndrome, or in pregnancy, hypertension, and we see more incidence of CSCR in sleep apnea. Patient usually comes with a complaint of blurred vision. There is a central relative scotoma. Patient says, I cannot see the central area. The adjoining area I can see. There is a metamorphopsia, dyschromatopsia, hypermetropization of the vision, meaning thereby if we ask the patient to read with 1 plus 1.5 diopter cylinder, patient comes to 6.6 vision. Micropsia. The diagnosis usually established on 90D or indirect ophthalmoscopy. On examination, you will see a central blister-like thing in the foveal and the macular region. Indirect ophthalmoscopy. Indirect ophthalmoscopy is done to identify all the margins of the blister, because if you miss the inferior margins, many times it can confuse Many times, inferior retinal detachment can mimic as in serous detachment on the macula. So indirect ophthalmoscopy is a must. BCVA improves with plus 1.5 diopter spherical, that is the hallmark of central serous retinopathy, meaning thereby there is not a total loss of vision as in retinal detachment. If you see this yellow dots here, these dots are subretinal precipitates and is a sign of central serous chorioretinopathy. Uh, if patient comes with these complaints, patient is usually subjected to OCT, then fluorescein angiography and ICG is mainly for diagnostic research purpose. This is one of the patient. You can see a large blister here on the temporal part of the macula involving the fovea. There is an exudation here above the fovea. We did a fluorescein angiography. You can see this white thing. These are pigment epithelial detachment. And from one of the pigment epithelial detachment, you can see an hyperfluorescence leak, which is increasing on subsequent photographs and presenting as an ink blot lesion. OCT shows subretinal fluid, which is hallmark of central serous retinopathy. This is another patient of central serous retinopathy. You can see juxtafoveolar leak. Uh, this patient, we did an OCT. You can see the vertical pictures. You can see a subretinal fluid. On horizontal picture, there is a pigment epithelial detachment. This patient underwent low fluence PDT, and you can see a resolution of fluid in this patient. Uh, CSR are, can also be classified as typical CSR, or it can be in atypical CSR that is associated with retinal pigment epithelial detachment. Leaks on FA can be a single leak, that is ink blot, or it can be a smokestack or inverse smokestack. There can be a multiple leaks. If the CSR is very large and involving the inferior retina, we call it as a giant central serous retinopathy. And it can also be classified according to the chronicity. It can be acute or chronic central serous retinopathy. This is one of the patient of giant central serous retinopathy. This patient had almost inferior detachment. And if you look into the fluorescein angiographic picture, you can see multiple leaks, which is increasing on late phase. Uh, this is another patient of chronic CSR. You can see that this snail track appearance um, defines the patient, that this patient has had multiple attacks of central serous retinopathy, and because of serous detachment, there is a pigmentary degeneration in this area. In this patient, if you see, we have done laser also, and every 3 to 4 months, patient used to come with blurring of vision and decreased vision. And you can see here leaks suggestive of central serous retinopathy. We did an OCT for this patient. There is a subretinal fluid within retinoschisis, and in the right eye, you can also see subretinal fluid. This patient underwent photodynamic therapy, and after 3 weeks of photodynamic therapy, you can see a total resolution of fluid in these cases. Coming to the differential diagnosis, pachychoroid spectrum, this spectrum I'll discuss in detail in later part of my talk. PCV, optic nerve head pit, inflammatory disease like VKH and AMPP can be confused with central serous choroidoretinopathy. Many choroidal tumors also presents as subretinal fluid, and you have to distinguish this subretinal fluid with the choroidal tumors. This is one of the patient of pachychoroid. I'll discuss later. This is one of the patient. You can see double hump PED with double layer sign suggestive of PCV. And this patient was initially diagnosed as CSR, but because of the typical OCT findings and ICG pictures, we came to a diagnosis of PCV. This patient, you can see there is an on red free picture. You can see there is a massive serous detachment on the posterior pole. And if you see this area, there is an optic nerve head pit. And high resolution OCT scan shows an subretinal fluid with an optic nerve head pit. Actually, these patients, fluorescein angiography, you will not find any leak, and typical OCT pit on the optic nerve head will clinch the diagnosis for you. In Vokianagi-Harada syndrome, it's a bilateral panuveitis. There is a sudden blurring of vision. On the posterior pole, you will see an exudative RD. OCT will show subretinal fluid. The hallmark of Vokianagi-Harada syndrome is yellowish-white precipitates, point-point lesions at the level of retinal pigment epithelium. CSR is many times confusing. If you miss the early phase, you will miss hypofluorescence. So it's important to catch an early phase in Vokianagi-Harada syndrome, which will show hypofluorescent lesion, which will start leaking in the late phase. And in late phase, you will see pooling. So this is an inflammatory disease where a steroid is the line of treatment. Observation will worsen these patients. There is currently no standard of treatment of central serous chorioretinopathy. Various modalities has been tried like focal laser, transpupillary thermotherapy, photodynamic therapy, ICG-mediated focal laser, intravitreal bevacizumab, drug like rifampicin, ketoconazole, propranolol, epinephrine are used with limited success. If patient comes to you with the first episode, that is an acute central serous retinopathy, then these patients are observed. So a baseline imaging is done in these patients. These patients are counseled to change their lifestyle, and stress should be relieved. So we ask this patient to do some meditation and sleep on time and get up on time and maintain a healthy routine. It's important to rule out that patient is not on any kind of steroids like screen creams, inhaler, or any homeopathic medication, because we know that steroid can worsen central serous retinopathy, and we have seen a small blister like CSR worsening into a giant central serous retinopathy after taking steroids. This is one of the patient. You can see a blister-like swelling in the temporal involving the macula. On fluorescein angiography, we see an ink blot leak. This patient was observed for a period of 6 weeks to 2 months, and there was a spontaneous resolution of central serous retinopathy. This is an OCT picture showing a spontaneous resolution of subretinal fluid and return of normal foveal contour, and patient improved to normal vision after a period of 4 to 6 weeks. Usually, we observe this patient between 2 to 2.5 months, that is 8 to 10 weeks. If there are certain high demand jobs like drivers, bilateral, if there is a bilateral involvement, if patient is on steroid because of some systemic disease, and if it is a recurrent central serous chorioretinopathy, then early treatment is recommended. If there is a recurrent central serous retinopathy or a chronic central serous retinopathy, chronic means above 10 weeks, and recurrent means once the fluid has absorbed and returned back after 3 to 4 months, then a repeat fluorescein angiography is done. The leaks are localized in AV phase and mid phase, because it's essential to localize, have the photograph of AV phase and mid phase, because these phase will define where the exact leakage is. And if it is away from the fovea, minimum 715 microns away from the fovea, then you can go for a gentle focal laser photocoagulation. Few spots of 200 micron, not too close to fovea, is given. The spot should be very gentle. It should be whitish. It should be yellowish in color, or you can do a photo fermentation kind of a laser. The results are generally good, and recurrences are reduced. This is one of the patient of recurrent CSR. You can see a pigment epithelial degeneration here, and there is a leak in this area. in the right eye, and the left eye also has pinpoint leak, which is not increasing over a period of time. We took this patient for focal laser. It's important to mention here that resolution of SRF takes somewhere between 2 to 4 weeks. And these things you have to explain to the patient, because patient thinks ki laser is a wonder, and after doing laser I'll be able to see things better by next day. So you have to counsel the patient that after laser it takes almost 2 to 4 weeks for the subretinal fluid to disappear and vision or the scotoma to decrease. Um, Even once the SRF disappears, it takes 3 months for the contrast sensitivity to return back. Patient will come and tell ki, I can see red light better from this eye, but in the affected eye, the red light is dull. So you have to explain to the patient that contrast sensitivity after resolution of subretinal fluid takes at least 3 months after focal laser or resolution of fluid. The same patient, you can see we have done laser here, and on OCT, you can see the left eye, there is a total resolution, and right eye, there is a decrease in fluid. And this patient was a doctor, and he regained his vision to 6 parts. Uh, in recurrent CSR or chronic CSR, where the leak is subfoveal, we cannot do a green laser or a thermal laser because it will the uh, uh, damage the foveal area. So various other options has been tried, like acetazolamide, rifampicin, eplerenone, bevacizumab, mifepristone, uh, finasteride, and ketoconazole, and H. pylori treatment. Each of the treatments we'll discuss in detail, uh, but these treatments are questionable. Nobody is sure which things work. Uh, but one thing which works is not available, that is photodynamic therapy. Eplerenone is an aldosterone antagonist, is given in the dose of 50 milligram OD or 25 milligram BD for 5 weeks. It is usually used in high BP patient or congestive heart failure patient. It blocks the aldosterone. Uh, this blocks the amount of sodium and water in the body, has been used anecdotally, and there are various reports where it has shown improvement. There is an trial which is RCT, which showed eplerenone has no role in central serous retinopathy. But many reports suggest that eplerenone do benefit patients in subfoveal leak. This is one of my patient. You can see there is a central serous retinopathy with an exudates, lot of exudate. And if we did a fluorescein angiography in this patient, and you can see a pinpoint leak in the early phase, which increases to an ink blot leak, confirming the diagnosis of central serous retinopathy. And this leak is right in the over the fovea, so we cannot do a focal laser. uh, PDT is not available, so we had put this patient on Epitus 25 milligram BD, and over a period of 8 to 10 weeks, you can see a total resolution of exudates and fluid. This patient returned back to 6/9 vision, but there was a small deficit in vision because of this pigment epithelial detachment. Rifampicin is given in the dose of 300 milligram twice a day. Rifampicin increases the metabolism of endogenous steroids, though its induction of, through its induction of the enzyme cytochrome. Has been used in small series to treat chronic central serous retinopathy with success. Patients who have exudative central serous retinopathy or multiple leaks responds to rifampicin. This is one of my patient I treated somewhere around 10 years back. You can see a large subretinal exudate with a blister-like swelling suggestive of central serous retinopathy. On angiogram, you can see there is an diffuse leak. And we started this patient on rifampicin. Within 10 days, amazingly, the fluid disappeared, and this exudate also shrunk, and this patient regained his vision to 6/6 in 2 weeks. Uh, me Pristone is an antagonist of glucocorticoid and progesterone receptors. It has weak anti-androgen action. Also, mifepristone inhibits cortisol-induced peripheral vasoconstriction. Its treatment response was seen in group of 16 patients with chronic central serous chorioretinopathy treated with 200 milligram daily mifepristone for 12 weeks. Personally, I don't have any experience about this drug. Many reports are available about bevacizumab, uh, but it is important to know that CSR is not a VEGF-related disease, and a small case series has shown potential benefit treating central serous chorioretinopathy with Avastin. But however, another case series showed no beneficial effect of Avastin in central serous chorioretinopathy. In my experience, these drugs do not work in central serous retinopathy because there is no VEGF related disease. Why some patient responded to bevacizumab in small group of patients? These patients were pachychoroid disease, and we will discuss these diseases in later part of my presentation. Uh, Finasteride is an inhibitor of dihydrotestosterone synthesis. 5 milligram daily was shown to elicit a positive response in small series of patients with chronic central serous retinopathy with recurrent exudation noted after discontinuation. Ketoconazole exerts its potential effect in the treatment of CSC by inhibiting some steps in steroid synthesis, resulting in decreased level of cortisol, androgens, and aldosterone, and in elevated progesterone. H. pylori treatment, there is a study which says that in patient of central serous retinopathy, the incidence of H. pylori was higher. And once the patient was treated with metronidazole and amoxicillin 3 times daily for 2 weeks, the height of the central serous, height of the SRF decreased over a period of time. But I don't have any personal experience of treating a patient of CSR with H. pylori. PDT in chronic central serous retinopathy acts by closing or narrowing vascular channels in choriocapillaries. But the problem with full dose, full fluence PDT uh, can cause complications like choroidal ischemia or CNV or RP atrophy. So, Smitching et al. Utilized half fluence PDT in acute central serous retinopathy with good results. We have a series of 23 patients. We did a low fluence full dose PDT in chronic CSR and subfoveal leaks. All patients except two responded to the treatment. Patient which did not respond to the treatment later turned out to be PCV as they came with a large subretinal bleed after 6 to 8 months of doing PDT. Two patients had retinal schisis, responded well to the treatment, which we have showed before in the presentation. There was no side effects seen in any of the patient, and there was no decrease in vision or macular ischemia. This is one of the patient. You can see a ink blot leak inferior to the fovea and with large subretinal fluid. We did a photodynamic therapy to this patient. You can see the leak has disappeared and the fluid decreased over a period of time. And this patient improved from 624 to 66 part vision. But now the problem is that Novartis people has withdrawn photodynamic therapy. So the patients with subfoveal leak cannot undergo photodynamic therapy. So I have tried anti-VEGF, which has an action on choroid, can be considered, like alpha-aflibercept or newer anti-VEGF, that is brolucizumab. This is one of my patient of pachychoroid disease with chronic CSR with retinoschisis. You can see a retinoschisis, and I gave injection brolucizumab to this patient First week there was no response, but after 2 to 3 weeks there was an absolute flattening of the edema, and this patient retained good vision. Coming to the pachychoroid disease, which is a new entity, and many people say, or the concept is coming that all central serous chorioretinopathy are patients of pachychoroid disease. Before going into the details of pachychoroid disease, we have to understand what is choroidal thickness and how to measure choroidal thickness. This is one of the patient. You can see good pseudophakia. Fundus is almost normal. Vision in the right eye was 618 and in the left eye was 66. Color vision and fields were normal. OCT, if we see, you can see a normal foveal contour in both the eyes. Then why the vision is less? So we did an EDI OCT, and if you see the thickness in the left eye is normal, while in the right eye the thickness has reduced to 180 degree. And because of this reduce in thickness, there is a lot of tessellation here in the fundus. So we come to a new diagnosis, that is age-related choroidal atrophy, and this is only possible to diagnose with the aid of EDI OCT or swept source, or what we call as an SSOCT. It's a newer imaging technique. EDI OCT, swept source OCT, ICG angiography, and autofluorescence help us to diagnose cases which are difficult to diagnose on conventional imaging modalities. In conventional OCT, imaging of the choroid is impeded by blood vasculature and melanin pigment, and the zero delay line is placed at the posterior vitreous. In EDI OCT, the zero delay line is placed on the inner surface of the sclera. Uh, Then the choroid can be better visualized. In SSOCT, longer wavelength was adopted, that is 1050 nanometers versus 840 nanometers in SDOCT. Detectors were used instead of CCD camera. Scan speed is twice as SDOCT, and you get a wide field scan, that is 12 millimeters versus 6 to 9 millimeters. Uh, these features help in visualization of layers of choroid, that is Sattler's layer, Haller's layer, lamina suprachoroidal. Longer wavelength allows visualization also in hazy media. Uh, what is to interpret what is thin and what is thick? First, you should know what is normal. Choroidal thickness is measured from outer border of retinal pigment epithelium to the inner border of sclera by digital calipers. The mean subfoveal choroidal thickness in a normal individual aged 50 years is around 287 microns, that is 300 microns. Every decade, there is a decrease of choroidal thickness by 15.7 microns, and many times you can see a diurnal variation. Pachychoroid means thick. In pachychoroid spectrum, it includes central serous chorioretinopathy. The second presentation of the pachychoroid is pigment epitheliopathy. You can have an pachychoroid neovasculopathy, which we will refer as PNV, and polypoidal choroidal vasculopathy, which we will refer as PCV. So, what you understand from pachychoroid spectrum is central serous retinopathy, pachychoroid neovasculopathy, and polypoidal choroidal vasculopathy is and disease of same spectrum and different time of life. It will present in a different way, and we'll see with subsequent examples on clinical examples how patient of central serous retinopathy initially was diagnosed, uh, or a patient of PCV was initially diagnosed with central serous retinopathy, and later we learned it turned converted into an PNV or a PCV. Uh, this is one of our case. We started this patient in somewhere around 2011. Patient came with an SRF with an yellowish white lesion temporal to the macula. We did an fluorescein angiography, and it appeared that this is a patient of an uh, occult CNV. Uh, we gave multiple injections of Lucentis. Each time the vision of the patient was 6:6. Each time the fluid used to decrease. After 4 to 5 injections, this fluid stopped responding to anti-VEGF treatment. Gave 4 injections of Lucentis. Lesion did not dry. Shifted to Avastin. Blood fluid increased. So we thought ki we are missing something. We did an ICG and fluorescein angiography simultaneously. You can see a pinpoint leak. So we came to a diagnosis that this is a central serous retinopathy. Um, at that time in 2011, we also got a Heidelberg imaging system, and we did an EDI OCT. And if you see the choroidal thickness is increased, and there is a large choroidal pachy vessel here. You can see this empty area here. This is a large choroidal pachy vessel which is pressing the retinal pigment epithelium and causing a small pigment epithelial detachment with subretinal fluid. With discussion among our group what to do this for this patient, we uh, did an photodynamic therapy for this patient, and you can see there is a total resolution of the fluid after one photodynamic therapy. Interestingly, this patient remained quiescent for 8 years and came in 2019 and had a presentation like PCV. So you can see initially this patient presented as central serous retinopathy or a pachychoroid disease. PDT was done, and after 8 years, this patient uh, came with features of PCV. So this patient helps us to understand that a patient of central serous retinopathy with pachychoroid can convert into an PCV or a polypoidal choroidal vasculopathy. So, meaning thereby CSR, pachychoroid, and PNV are spectrum of the same disease at different points of life. This is one of the patient of pigment epithelial detachment involving the fovea. And we, as conventional teaching goes on, we see that pigment epithelial detachment does not needs to be treated. We followed this patient for 2 years, and after 2 years, this patient comes with a blurring of the vision. And on OCT, you can see there is an SRF with a large PED. We did an fluorescein angiography, and you can see a classic membrane inside the pigment epithelial detachment. But interestingly, if you do an EDI OCT here, you can see there is a very thick choroid. The thickness of the choroid is somewhere around 402, and there is a large pachy vessel just beneath this pigment epithelial detachment, causing dysfunction of this retinal pigment epithelium, leading to the pigment epithelial detachment and a CNV formation over a period of time. This is another interesting patient came in 2016 with an inferior retinal detachment. Once we did an fluorescein angiography, we found there were multiple leaks, and there was an exudative kind of a lesion inferior in infranasal quadrant. And with this, we made a diagnosis of an multifocal CSR. We went ahead and did focal laser to all this lesion, and patient was quiet for 4 years down the line. In 2019, this patient comes with a picture like this, which is you can see an RP complex technique with SRF, and you can see an CNV formation in a patient of a CSR. At this time, we looked into the choroid, and you can see there is an thickened choroid suggestive of an pachychoroid disease. So pachychoroid spectrum, first this patient presented as CSCR, and later after 4 years, this patient came with an PNV-like picture. So the third point is uh, same patient can develop neovascularization over a period of time. To summarize, Central serous retinopathy is the fourth most common macular disorders in clinical practice. Diagnosis is clinical and with OCT. FFA is planned in non-resolving CSCR. 70% of CSCR responds to supported treatment. Focal laser is recommended for extrafoveal leaks. PTT low fluence is done in chronic, recurrent, and subfoveal leaks. In chronic and recurrent CSCR, OCT EDI should be done to diagnose pachychoroid spectrum. In absence of PDT, newer anti-VEGFs like brolucizumab and aflibercept should be tried. Thank you very much for your kind attention.
So we have some questions from the hot seat participants and from YouTube and Facebook. The first question is, so what is the duration which we consider for acute and chronic CSR?
Usually what the book says, you wait for 3 months, it's an acute, and after 3 months, we label this patient as chronic CSR. But in practice, we generally take 8 to 10 weeks.
So Dr. Soini has asked difference between typical and atypical CSR.
Typical CSR will only involve the posterior pole. Atypical CSR will have a retinal pigment epithelium. Many times it will also present as an inferior bullous RD, which also appears like an inferior RD or a giant central serous retinopathy.
So you have shown us the FFA picture of CSR. So can you please tell us what features are suggestive of acute and what features, if present, are suggestive of a chronic case if the patient presents to us in the first sitting and we're not sure of the history before?
First thing is the history is very important. Patient comes with a complaint. You will ask the patient for how long the vision is less. If the patient is complaining 15 days, 20 days, then you label this as an acute central serous retinopathy. On clinical examination, if you find an tract of RPE degeneration inferiorly, or there is a pigment mottling on fundus fluorescein angiography, then you know it's a recurrent CSR causing a damage to the retinal pigment epithelium.
Dr. Soini also asked, can chronic recurrent CSR develop in a patient unilaterally? Can it happen in a patient who has only unilateral disease, chronic and recurrent CSR?
Yes, it can happen in unilateral disease. Chronic and recurrent CSR can happen in unilateral disease.
So there is another question. In case of CSR with PED, do we have to rule out PCV by ICGA?
Not in conventional CSR. You need to do an ICG, but in patients where it's not resolving, fluorescein angiography picture is not very clear. You don't see any kind of a focal leak. OCT in PCV is very characteristic. You have an big PED with and double hum or a double layered sign. Then OCT can give a clue that what you are dealing is in PCV. So because ICG is not available in many of the centers and many of the cities, ICG is only available in few tertiary care centers. So I think ICG is diagnosis of PCV nowadays is made clinically and on OCT. If you have a large subretinal bleed with CNV with double hump PED, yes, you can make a diagnosis of PCV, but ICG is diagnostic in cases of PCV. It's not I cannot say कि if you don't have an ICG, you cannot diagnose PCV because PCV, OCT features of PCV are very characteristics.
So if a patient has acute CSC, how do we decide whether to treat the patient or to observe?
90% if patient comes to me with a complaints of 15-20 days, I will just observe the patient. I'll counsel the patient कि you have to decrease your stress in life. You have to sleep at a particular time and get up at particular time. लाइफस्टाइल चेंजेस करने की जरूरत है इसमें. पार्टीज कम करने की जरूरत है और टेंशन लेने की जरूरत नहीं है. आप किसी पे ज्यादा गुस्सा होता हो, अगर टेंशन होती है तो आपको CSR रिजोल्यूशन में ज्यादा परेशानी होगी. So you have to counsel patient. You also have to tell patient to meditate because meditation many times decreases the cortisol level and patients comes within a resolution of central serous retinopathy. Patients if my criteria of going for treatment is if there is a worsening of the vision. Like if patient comes to me with a 6/12 vision and I follow the patient after 15 days and patient has worsened to finger count vision. So I'll like to go for an early treatment in these patients. There are certain job situations which are highly demanding. First thing is if you have a driver or a pilot, I'll go for an early treatment. If it's a recurrent CSR, because every time the CSR comes, it will leave some kind of a retinal pigment epithelium. I'll ask for an fluorescein angiography and an early treatment. If it affects both the eyes, then early treatment is recommended. That is before 8 to 10 weeks. Ideally, it should be done after 8 to 10 weeks. So once the patient comes to me, I'll just do an imaging that is OCT. I won't go for a fluorescein angiography at the first hand. I'll counsel the patient to decrease, change their lifestyle, do some meditation, go to a church, temple, or mosque where you can get peace. And if uh, 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 if all this I'll call the patient after 2 weeks or 2 to 3 weeks. If the duration is 8 to 10 weeks and the CSR is not resolving, or I do not see any sign of resolution, like many times you will see subretinal precipitates coming. If subretinal precipitates on clinical examination, that means it's a resolving CSR. I won't go for any other imaging. I'll just wait for another 2 weeks. If the patient does not improve over a period of time, then I go for an fluorescein angiography, and 90% of time it's an extrafoveal leak where we go for an focal laser photocoagulation. Important thing doing focal laser photocoagulation is you should have a large image of the fluorescein angiography of AV phase. The point of leakage should be pinpoint. Then you have to trace the leak. Once the leak or the vessel, you have to trace from where it is leaking, and you have to exactly go there and give 1 to 2 spot. Important thing is you have to give a very gentle burn. You don't have to give a very strong or a chalky white burn, because chalky white burn can cause an RP damage and can lead to an CNVM formation in later part of the life. So it should be what I call as an photo fermentation of the retinal pigment epithelium. It's not photocoagulation of the retinal pigment epithelium. The right word for focal laser will be photo fermentation of the retinal pigment.
So that is about the in acute condition, and how do we follow up? Yes. The patient has acute CSR. How often do we follow? And do we repeat the FFA in every visit?
Every time there are three criteria to follow up a patient for central serous retinopathy. One is vision. Second thing is a clinical examination. Last thing is an OCT, uh, which will tell you whether the height of the fluid is decreasing or not decreasing. If my vision and on clinical examination there are subretinal precipitate, I will not repeat any imaging. I'll just go for a clinical examination. It's not necessary to do an OCT at every visit. You can diagnose these patients on vision and clinical examination. And my preference is I generally don't repeat an OCT. I will wait for 8 weeks. And if it's not resolving, then I'll go for an fluorescein angiography because my plan is to treat this disease after 8 weeks.
So there are multiple, there are quite few people who have asked the role of eplerenone. Even, yeah, you have explained, but can you please tell again?
Eplerenone, there are controversy about eplerenone. There is an VC trial which is an randomized controlled trial, which says that eplerenone does not have any role. But there are 4 to 5 trials. One is from Israel and one is from Europe, which says eplerenone has a role in decreasing the subretinal fluid. So I generally don't use eplerenone as a routine. I use eplerenone whenever there is an leak in subfoveal area. Uh, that is my indication for eplerenone. Otherwise, what I do, observe for 8 to 10 weeks. If not resolving, go for focal laser. Subfoveal leak, I'll go for Epitus or eplerenone. Because now I don't have PDT in my armamentarium.
Sir, Dr. Divya asked if a patient has contraindication to eplerenone, but he has recurrent CSR, then how do we go about for this patient?
How do we, in recurrent CSR, you have to do an fluorescein angiography, and if there is a leak, you have to laser this leak with a green laser. There was a question whether you can use alfrabesept or recurrent or brolucimab in these patients. I restrict my patient of chronic CSR who has an pachychoroid disease, which is not responding to any other form of treatment. I'll go for an injection of anti-VEGF only after 4 to 6 months, not at an initial stage.
So there is one question by Dr. Abhishek. How to differentiate acute CSR versus exudative RD involving the macula?
CSR, you will have in exudative RD, you will have a shifting fluid, which is not there in central serous retinopathy. And if you have an exudates like what I showed in that patient, then you go in for an fluorescein angiography. Exudative RD, anyhow, if you are diagnosing exudative RD, two things are mandatory. One thing is in fluorescein angiography, and second thing is in ultrasound. Fluorescein angiography is done to rule out any tumors. And if you find a typical leak, what you see in fluorescein angiography, then you are going to diagnose it as an exudative, as in central serous retinopathy, appearing like in giant CSR. But if you have any tumor mass or a choroidal hemangioma or melanoma, which can also present as an exudative RD or metastatic lesions in the choroid, which can mimic like central serous retinopathy. On fluorescein angiography, that will show a diffuse early it will show filling with leakage in the late stage. It will not show a in-blot leakage or a pinpoint leakage, which is increasing. So in these kind of cases, clinical examination with fluorescein angiography and a B scan is mandatory.
So another similar question is how to differentiate fibrinous CSR from choroiditis.
From
Choroiditis.
see CSR, many times pictures what I showed you where there is an yellowish kind of an exudation in the uh, uh, lesion or the blister. So you have to do an fluorescein angiography in these patients. In choroiditis patient, you will have an hypo followed by an hyper. That will give a diagnosis of choroiditis. But in CSR, you will have pinpoint leaks, which is increasing. It will be an either ink blot leak or it will be a smokestack leak. So fluorescein angiography is must. OCT or EDI OCT will show a thickening of the choroid in both the disease. The fluid or the SRF in choroiditis is not much as compared to a CSR. CSR, you will have in huge height, but in choroiditis, you will have a very thin layer of fluid. So OCT will also tell whether it's in choroiditis or a central serous.
So there is a question asking on the mechanism of PDT and to explain about low fluence.
What does it is a sub-threshold laser. So what it does, it decreases, it causes a vasoconstriction of the choroidal vessels. Once there is a vasoconstriction of the choroidal vessels, hydrostatic pressure decreases in the choroid, thereby the leak decreases. And what was the second question?
Low fluence.
Low fluence, the usual fluence is 6 millijoules per centimeter square. So once you do a full fluence PDT, that is 6 joules per centimeter square, you reduce it to 3 joules per centimeter square. You make it as half. There is two concepts. One is full half fluence, full dose, and there is half fluence and half dose PDT. Okay. What we have done in our study is half fluence and full dose. There are also literature available on half fluence and half dose PDT. You make the dose half. Basically, it works by decreasing the dilated choroidal vessels and decreasing the hydrostatic pressure. There is also multiple, and we have also calculated the choroidal thickness after PDT. And in our series of patients, the choroidal thickness decreased by somewhere around 30% once we have done photodynamic therapy, meaning thereby there is a decreased engorgement after photodynamic therapy. The second advantage of doing a low fluence full dose PDT, the chances of recurrence has reduced over a period of time. So if you have a very recurrent CSR, you go for a photodynamic therapy. But the main problem nowadays is that we don't have PDT in our armamentarium because Novartis people has withdrawn the dye visually. Other thing what you can try is TTT, that is transpupillary thermotherapy, which is also a sub-threshold laser with an red laser, which decreases, which treats the choroid, and it also gives a similar results.
So, Dr. Talwar is asked the role of decreasing IOP and the role of diuretic in treatment of CSR.
Diuretic decrease?
Role of decreasing intraocular pressure.
I don't think so. Diuretics, there was some initial literature available which said that Diamox can be helpful. And Diamox was helpful in a role of increasing the RP pump but not decreasing the intraocular pressure. Dorzox and Diamox there is a role by increasing the role of retinal pigment epithelial pump, thereby pumping subretinal fluid out into the choroid, thereby helping to decrease the height of central serous retinopathy. But uh, there is no definite role of Diamox or dorzolamide in treating CSR.
So, CSR, like, they usually occur in young male who has history of, steroid use and all that. But there is a question asking if it can happen in children, and if it happens, how do we manage?
Children, it's a rare entity of central serous retinopathy, and if it happens, you have to look into other causes of serous detachment in these patients.
Mm.
But I have not seen patients of CSR in children.
Okay. So there is another question. How do we identify the sclera in OCT?
Can I go back to my presentation?
Yes, sir.
See, you can see here in this. This is the sclera, and these choroidal vessels. These are choroidal vessels. So a hyperreflective line on OCT is the sclera. This is the sclera. What you see here is a sclera. Again, if you see here, this is sclera, and I'll show you one more picture here. You can see this picture. You can see this is the sclera. This is wide angle with OCT angio. This is Serous 6000. And this is the sclera and this is the choroid. So you can measure the thickness with the help of the calipers. This high reflective area, what you're seeing is the sclera.
Mm. So there is a question. So to say pachychoroid spectrum, we have to measure the choroidal thickness. Where do we measure the choroidal thickness?
Ideally, it should be measured subfoveally.
So I think that's all the questions we have for today. Thank you for answering each one of them so thoroughly. Yeah.
Thank you, Mary.
Next class will be on Friday, and the topic is optic disc anomalies and fits, and it will be taken by Dr. Sarap. We hope to see each and every one of you again. Thank you so much, sir.
Welcome, welcome. Thank you very much. I thank you, Mariam, Dr. Deepti Kurian, Sohani, and Divya, and especially Dr. Santosh Onawar, Dr. Lalit, Dr. Mahipal, and Ritika Sajdev for giving this. Thank you very much. Thank you very much. Can I leave the meeting?
Yes, sir. Thank you, sir.